Everyone in the trauma bay froze, except the woman in the corner with copper-red hair pulled tight against her skull. For more stories like this, subscribe. Dr. Marcus Brennan didn't look up from his phone when she walked into the surgical prep room. He was scrolling through something, expensive watch catching the fluorescent light, silver hair perfectly combed even at the end of a 14-hour shift. "You're the new second year," he said. Not a question, a dismissal. Claire Ashford pulled her hair back, fingers moving with mechanical precision, each motion economical. "Yes, sir, Dr. Ashford." "Ashford." He finally looked at her, eyes moving from her face to her hands to the way she stood, weight balanced, shoulders square. Something flickered across his expression. "Your file says you completed first year at, where was it?" "County General, sir." "Right." He set his phone down. "County General. Well, this is St. Catherine's. We do things differently here. Real surgery, not field medicine." The other residents in the room went quiet. Yuki Tanaka, a third year with dark eyes that missed nothing, glanced up from her tablet. Claire didn't respond, just nodded once, pulled on her surgical cap, checked the board mounted on the wall. 3 cases scheduled for the night. Appendectomy in Bay 2, gallbladder in Bay 4. Motorcycle accident coming in hot. ETA 12 minutes. Ashford. Brennan was watching her. "You take the appendectomy. Simple case. Should be manageable for someone with your background." The way he said background made it sound like something distasteful. "Yes, sir." She moved toward the scrub station, turned the water on, began the methodical process. Soap, forearms, wrists, fingers. The rhythm was automatic, her mind already 3 steps ahead, visualizing the procedure, the incision, the layers of tissue. Behind her, she heard one of the first-year residents whisper to another, "She's the one from county, right?" Heard she barely passed her boards. "Brennan doesn't think she belongs here." Can you blame him? Look at her. She looks like she's about to fall asleep. Claire kept scrubbing. The water was too hot, steam rising, but her hands didn't shake. They never shook anymore. Not after Bagram. Not after Kabul. Not after that last convoy outside Kandahar when the IED went off and she'd performed 3 surgeries in the back of a moving vehicle, with nothing but a headlamp and a combat medic holding a flashlight with his teeth. But they didn't know that. They saw a second-year resident who transferred from a county hospital, someone who probably couldn't cut it at a real teaching institution, someone Brennan had already decided wasn't worth his time. She dried her hands. Backed through the door into the surgical bay, arms up, letting the scrub nurse glove her. The patient was already under, monitors beeping steady, vitals displayed on screens that wrapped around the room like a command center. Patient is David Morrison, 28 years old, acute appendicitis, the anesthesiologist said. He was older, gray stubble on his chin, eyes tired. Vitals stable, no known allergies, CT showed classic presentation. Claire approached the table, looked down at the man's abdomen, already prepped and draped in blue surgical cloth. She didn't touch him yet, just looked. The slight distension, the way his breathing moved the drape, the color of his skin where it showed at the edges. Something was wrong. "Scalpel," she said. The scrub nurse handed it to her, metal cool against her palm, weight familiar as breathing. She made the incision. Standard McBurney's point. The blade moved through skin, subcutaneous tissue, fascia. Muscle separated under her fingers. Everything routine, except the smell. The moment she opened the peritoneum, it hit her. Not the clean, almost neutral scent of a standard appendectomy. Something else. Something sour and dark and wrong. "Suction," she said, voice unchanged, but her mind was already recalculating, rewriting the procedure in real time. The suction cleared the field, and she saw it. The appendix wasn't just inflamed, it was perforated. And the perforation wasn't fresh. "This isn't acute appendicitis," she said. "This is a ruptured appendix with established peritonitis. He's septic." The anesthesiologist looked at his monitors. "Vitals are stable. For now." Claire's hands were already moving, exploring the abdomen, checking for abscesses, for contamination. "He's compensating, but his white count was elevated on admission, wasn't it?" Silence. "Wasn't it?" she repeated, not looking up, fingers tracing the edge of the rupture. Assessing damage. Yes, 18,000. And his temperature? 101.4. He's been symptomatic for at least 3 days. Claire's voice was calm, factual, the way it had been when she'd briefed colonels on casualty reports. The CT showed classic presentation, because everyone was looking for classic presentation. But the pain migration, the elevated inflammatory markers, the low-grade fever, this is perforated with abscess formation. She looked up then. Met the eyes of the scrub nurse, the anesthesiologist. Anesthesiologist, the first-year resident, observing from the corner. We need to convert this to an exploratory laparotomy. I need a full abdominal exposure, large Richardson retractors, extra suction, and get Brennan down here. The scrub nurse hesitated. Dr. Brennan is in Bay 4 with the gallbladder case. Then page him. This patient is going to crash in the next 20 minutes if we don't get ahead of this. Dr. Ashford, I don't think, page him. Her voice didn't rise, didn't harden, just carried the weight of someone who'd made calls like this when mortar rounds were landing 30 meters away. And the only light came from burning vehicles. The nurse paged. Claire extended the incision, moved with precision that looked slow but covered ground fast, each motion deliberate, no wasted movement. She found the first abscess pocket within 90 seconds, drained it, cultured it, moved to the next quadrant. The door banged open. Brennan stood in the doorway, still in his surgical gown from the other bay, mask hanging loose around his neck. What the hell is going on? You paged a stat surgical for an appendectomy? Claire didn't stop working. Perforated appendix with peritonitis and multiple abscess pockets. Patient is septic. I'm performing damage control and source elimination. You converted to an X-lap without consulting? There wasn't time to consult. You're a second-year resident. You don't make that call. The patient's condition made that call. Brennan crossed to the table, looked down into the open abdomen, saw the contamination, the abscesses, the inflamed tissue. His jaw tightened. You should have closed and consulted before proceeding. If I'd closed, he'd be coding right now. Silence filled the bay. The monitors beeped. The suction hissed. Claire's hands moved through the abdomen with the confidence of someone who'd done this hundreds of times. In worse conditions, with less equipment, Brennan watched her work, really watched. The way she held the instruments, the angle of her incisions, the speed and surety of her movements. Those sutures, he said slowly, that's not standard technique. It's effective technique. It looks like, he trailed off. Claire didn't help him finish the sentence, just kept working, kept saving the life on her table, kept being exactly who she'd always been. Whether anyone recognized it or not, if you want to see what happens when the entire hospital discovers who Dr. Ashford really is, make sure you subscribe to Emergency Hero Stories, because what she does in the next few days will leave everyone speechless. Where are you watching from? Drop a comment below. The surgery took 4 hours and 37 minutes. When Claire finally stripped off her gloves in the scrub room, the sky outside was starting to lighten, pale gray bleeding into black. David Morrison was stable in recovery, on broad-spectrum antibiotics, prognosis good. Brennan hadn't said another word to her after watching for 15 minutes. He'd just left the bay, door swinging shut behind him with a pneumatic hiss. Claire washed her hands, feeling the familiar ache in her shoulders, the tightness in her lower back from standing in one position for hours. The water ran clear. She watched it circle the drain, remembered other sinks, other water that had run red no matter how long she scrubbed. Dr. Ashford? She looked up. Yuki Tanaka stood in the doorway, still in scrubs, tablet tucked under one arm. Yes, that was, how did you know about the perforation? The smell. The smell? Perforated bowel has a distinct odor, different from acute inflammation. Claire dried her hands, precise movements, each finger individually. And the presentation was too clean. Real acute appendicitis is messier, pain is harder to localize. His symptoms were too textbook. Yuki nodded slowly, something working behind her eyes. Your suture technique. The interrupted pattern you used for the abscess pockets. I've seen that before. Claire went still. Just for a second, just a fractional pause, but Yuki caught it. In a research paper, Yuki continued. About combat surgery. Battlefield techniques for contaminated wounds. The pattern minimizes tissue tension and allows for drainage without compromising closure integrity. It's a useful technique. It's a military technique. Claire met her eyes. Lots of civilian surgeons use it, not second-year residents from county hospitals. The air between them held weight, a question forming that Yuki was too careful to ask directly. Claire could see her processing, filing information, building a picture that didn't quite match the official story. "I study a lot," Claire said finally. "Right." Yuki smiled, small and knowing. "You study a lot." She left, and Claire stood alone in the scrub room, listening to the hospital wake up around her. Shift change in 30 minutes. Morning rounds. The day team arriving, fresh and rested, taking over from the night crew, who moved like zombies through fluorescent hallways. She changed in the residence locker room, pulled on jeans and a simple gray sweater, tied her hair back. Her locker was nearly empty. No photographs, no personal items, just a change of clothes, deodorant, a protein bar she'd forgotten to eat 2 days ago. The locker next to hers belonged to someone named Patterson, covered in stickers and photos, a small mirror stuck to the inside of the door, motivational quotes written on index cards taped to the metal. Claire closed her locker, headed for the residence lounge. 3 first-years were sprawled on the couches, coffee cups scattered across the table, looking like they'd been awake for 30 hours straight, which they probably had. They went quiet when she entered. "Morning," Claire said, moving to the coffee pot. "Morning." One of them, a guy with dark circles under his eyes and a name tag that said Chen, watched her pour coffee. "Heard you converted an Appy to an X-Lap last night. Patient needed it." Brennan was pissed. "Patient's alive." Chen exchanged glances with the other two. "Yeah, but you're a second year. You're not supposed to make those calls without an attending." Claire sipped her coffee. It was terrible, burnt and bitter, but it was hot and caffeinated. Patient was crashing. There wasn't time. "How did you even know the CT was clean?" "CT showed what people expected to see." "That's not an answer." She looked at him over the rim of her cup. "Sometimes you have to trust what your hands tell you more than what the imaging shows." "Your hands." One of the others, a woman named Rodriguez, leaned forward. "Where did you train the 4-county?" "Different places." "That's vague." "It's accurate." Rodriguez smiled, but it didn't reach her eyes. "You don't talk much about yourself." "Not much to talk about." "Come on, everyone has a story. Med school, residency, why you became a doctor, the usual." Claire set down her coffee. "I became a doctor because people need doctors. I trained where I could. Now I'm here." "That's the story." "Brennan thinks you're hiding something." "Brennan thinks a lot of things. He called you unprepared, said your technique is unorthodox." "My technique saves lives. So does following protocol." Claire picked up her coffee again, moved toward the door. Protocol said David Morrison had acute appendicitis. Protocol would have sent him to recovery with a simple appendectomy. He would have coded within 6 hours from septic shock. "You tell me which approach saves more lives." She left before they could respond, walked down the hallway toward the resident's office, where she was supposed to log her cases and update patient charts. The hospital was bright now, sun streaming through windows, the night shift's chaos giving way to the day shift's organized urgency. Her pager went off. ER. Trauma consult. She changed direction, headed for the emergency department, coffee still in hand, mind already shifting gears from reflection to assessment. The ER was controlled chaos, beds separated by curtains, monitors beeping in overlapping rhythms, nurses moving between stations with practiced efficiency. Dr. Ashford, the charge nurse, a woman in her 50s with gray hair and sharp eyes, flagged her down. Motorcycle accident. 23-year-old male. Hit a guardrail on Route 93. Possible internal injuries. He's in Bay 7. Claire handed her coffee to the nurse, pulled back the curtain. The patient was young, conscious but pale, breathing shallow. Road rash covered his left arm, his leather jacket cut away by paramedics. The monitor showed elevated heart rate, blood pressure slightly low. "Hey doc," he said, trying to smile. "I'm okay, really just some bruises." Claire moved to his side, placed her hands on his abdomen. Firm but gentle, methodical pressure, working quadrant by quadrant. He winced when she pressed the left upper side. "Scale of 1 to 10, what's your pain level?" "Maybe 6, 7 when you push there." She listened to his chest with her stethoscope. Breath sounds diminished on the left side, heart rate fast. She pulled back, looked at his neck veins, slightly distended. "Get me a chest x-ray," she said to the nurse. "Portable, now." "Dr. Ashford, the patient seems stable. He has a pneumothorax, left side. His lung is collapsing." The patient's eyes widened. "What? No, I'm breathing fine." "For now." Claire kept her voice calm, the way she'd learned to do when telling 19-year-old privates they were going to be okay even when she wasn't sure they would be. Your lung has a small leak. Air is building up in your chest cavity. We need to release the pressure before it gets worse. The portable X-ray arrived within 3 minutes. The image confirmed what her hands had already told her. Pneumothorax, moderate size, lung compressed by about 30%. We need to place a chest tube, Claire said. The ER attending arrived, a doctor named Palmer, early 40s, competent but by the book. He looked at the X-ray, looked at the patient, checked the vitals on the monitor. Vitals are stable. We can monitor him, see if it resolves on its own. It won't resolve. It's going to progress. His O2 saturation is 94%. That's acceptable. It's compensatory. He's working harder to breathe. Look at his respiratory rate. 22. Trending up. In 2 hours. He'll be in respiratory distress. Palmer frowned. You're making assumptions. I'm reading signs. We don't do invasive procedures based on theoretical progression. Claire looked at the patient, at the slight blue tint starting to show around his lips, at the way his nostrils flared slightly with each breath, at the tendons standing out in his neck. She'd seen this before, knew exactly how it would play out, knew the moment when stable became critical, when monitoring became mourning. Tube thoracostomy kit, she said to the nurse. Palmer stepped forward. Dr. Ashford, I'm the attending here. You don't override my orders. Then give the correct order. Excuse me? This patient needs a chest tube. You know it, I know it. We can do it now, controlled and safe. Or we can wait until he crashes and do it as an emergency. Your choice, but make it fast because his SAT just dropped to 92. Everyone looked at the monitor. Oxygen saturation 92%. Dropping. Palmer's jaw tightened. Fine. Place the tube. But this goes in my report. Understood. Claire prepped the site, injected local anesthetic, made the incision with steady hands while the patient tried not to watch. The tube slid between the ribs into the pleural space, and the hiss of escaping air was immediate and unmistakable. The patient gasped, then breathed deeper. Color returned to his face within 30 seconds. Oh, he said. Oh, I can breathe. Claire secured the tube, connected it to the drainage system. You're going to be fine. Palmer stood back, arms crossed, watching her work with an expression somewhere between irritation and grudging respect. When she finished, he leaned close, voice low. Where exactly did you train, Dr. Ashford? Does it matter? When a second-year resident has the diagnostic instinct of a 10-year trauma surgeon. Yes, it matters. Claire stripped off her gloves. I pay attention. That's not an answer. It's the only one I have. She walked away, leaving him standing in the bay, and she could feel eyes following her, questions forming. The careful anonymity she'd built starting to crack at the edges. 2 days later, Claire was assigned to a gallbladder removal. Routine laparoscopic cholecystectomy. Scheduled procedure. Low risk. The kind of case they gave to residents to build confidence and hours. Brennan was supervising, standing at the back of the OR with his arms crossed, watching the monitors instead of her hands. The patient was a 56-year-old woman named Patricia Ellsworth. History of gallstones, recurring pain, straightforward surgical candidate. Claire made the small incisions, inserted the laparoscopic camera, began working with the instruments that turned her hands into tools moving on a screen. Clamp, she said. The scrub nurse handed it over. Claire isolated the cystic duct. Began the dissection. The gallbladder was inflamed, thickened walls, but nothing unexpected. She worked methodically, each movement precise, the camera showing everything in high definition on the monitors around the room. Then she saw it. A variation in the anatomy. The cystic artery wasn't where it should be. It branched differently, running posterior instead of anterior, hidden behind scar tissue from previous inflammation. She paused, repositioned the camera. Traced the vessels with her instruments. Problem? Brennan asked from the back of the room. Anatomical variation. The cystic artery has an aberrant branch. If I clip the standard position, we risk compromising blood flow to the liver. You're sure? Yes. She adjusted her approach, dissected more carefully, exposed the variation completely before proceeding. It added 17 minutes to the surgery, but when she clipped and divided the vessels, everything was clean. Controlled, safe. The gallbladder came out intact. No complications. No bleeding. Perfect visualization throughout. When she stepped back from the table, Brennan was standing closer, looking at the monitors with a different expression. Not quite approval, but something like reassessment. "How did you catch that?" he asked. "The variation?" The tissue planes didn't look right. The angle was off. Most residents wouldn't have noticed until they were already in trouble. "I wasn't most residents." The words came out before she could stop them. A slick, a crack in the careful neutrality she maintained. Brennan's eyes narrowed. "No, you're not." He left without another word, but Claire felt the weight of his attention differently now. Not dismissal. Scrutiny. In the residence lounge afterward, Yuki was waiting with her tablet and 2 cups of coffee. "Sit," she said. Claire sat, accepted the coffee. "What?" "I did some research." Yuki turned her tablet around, showed Claire a medical journal article. "Damage control surgery in austere environments." Published in the Journal of Trauma and Acute Care Surgery, 2020. Look at the author list. Claire didn't need to look. She knew what Yuki had found. Captain C. Ashford, MD, U.S. Army Medical Corps. Yuki read. Specialized in forward surgical team operations. 3 deployments to Afghanistan. Credited with developing modified resuscitation protocols for mass casualty events in resource-limited settings. The lounge was empty, except for them, quiet. The coffee machine hummed in the corner. "You were military," Yuki said. It wasn't a question. "I was. Army trauma surgeon." "Yes. And now you're a second-year resident. Why?" Claire drank her coffee, felt the heat spread through her chest. "Because military surgical experience doesn't transfer to civilian credentials the way it should. I have years of trauma surgery, but civilian residency programs don't recognize most of it. So I start over." "That's insane. That's bureaucracy." Yuki leaned back, processing. "How many surgeries have you done?" "I stopped counting after 800. "Jesus." Yuki's voice was quiet. "And Brennan treats you like you don't know which end of a scalpel to hold." "He doesn't know." "Why not tell him?" "Because I didn't come here to be the military surgeon. I came here to learn civilian medicine, to practice without command structures and evacuation timelines and resource scarcity, to just be a doctor." "You're more than just a doctor." "I want to be just a doctor." Yuki studied her face, seeing more than Claire wanted to show. "That paper you published, the resuscitation protocols, they've been adopted by trauma centers across the country. You literally changed how emergency medicine is practiced." "The team changed it. I just wrote it down." "Stop deflecting." Yuki's voice was firm. "You're not some random resident who got lucky. You're one of the most experienced trauma surgeons in this hospital, and everyone treats you like you're incompetent." "I can handle it." "That's not the point." Claire stood, set down her coffee. "I need to check on my patients." "Claire, thank you for the coffee." She left before Yuki could push further, walked the long corridor to the surgical ward where her post-op patients were recovering. David Morrison was sitting up, eating solid food, color good. The motorcycle accident victim was breathing comfortably, chest tubes still in place but drainage minimal. Patricia Ellsworth was awake and talking to her daughter, pain controlled, no complications. 3 patients, 3 saves, 3 people who were alive because she'd seen what others missed. But she felt tired, bone tired. The kind of exhaustion that came from carrying weight no one else could see. Her pager went off. "ER, multiple trauma incoming. All available surgical staff report immediately." She ran. The ER was transforming when she arrived, the controlled environment shifting into something else, something she recognized from muscle memory. Nurses moving equipment, techs prepping phase, the charge nurse directing traffic with sharp, efficient commands. "Construction accident," the nurse said. "Steel beam collapse at the Seaport District site. Multiple casualties. EMS is reporting at least 6 critical. First ambulance, 2 minutes out." Claire moved to Bay 1, started pulling on gloves, running through mental checklists. Airway, breathing, circulation, hemorrhage control. She could hear the sirens now, getting closer, that distinctive wail that used to mean incoming choppers and mass casualties and decisions made in seconds. Brennan appeared beside her, already gowned. "You take Bay 2, stabilize and assess. I'll handle Bay 1. "Understood." The first ambulance arrived. Paramedics rushed in with a stretcher, a man covered in dust and blood, hard hat still on his head, eyes wide with shock. "James Cordero, 41 years old, the paramedic called out. Crush injury to the chest and abdomen. BP 90/60. Heart rate 130. Responsive but confused. They transferred him to the bed in Bay 2. Claire moved immediately. Hands already assessing, eyes taking in everything at once. The way his chest moved asymmetrically. The distension in his abdomen. The pale, clammy skin. Start 2 large-bore IVs, she said. Type and cross for 6 units. Get me a fast exam ultrasound. The ultrasound probe showed free fluid in the abdomen. Blood. Internal bleeding. His chest had decreased breath sounds on the right side. Another pneumothorax or possibly hemothorax. We need to get him to surgery, Claire said. He's bleeding into his abdomen and his chest. She looked up, caught sight of the patient's face properly for the first time. He was staring at her, really staring. Not the blank stare of shock, but recognition. Doc? His voice was weak, confused. Doc Ashford? She froze. From Bagram? He tried to sit up. Couldn't. You were in Afghanistan. You saved my unit. The convoy attack outside Kandahar. I was the medic. You remember? You operated on Torres in the back of the Humvee while we were still taking fire. The ER went quiet. Everyone within earshot had stopped moving, stopped talking, stopped breathing. Claire felt the moment crystallize, felt her carefully constructed civilian identity crack and shatter like glass. Sergeant Cordero, she said quietly. Lee still. You're injured. You got us all out. All of us. Torres, Mackenzie, the lieutenant. Everyone said it was impossible, but you just kept working. His eyes were bright with pain and memory. You're a hero. Brennan was standing in the doorway between bays, staring. Yuki had appeared from somewhere, tablet forgotten in her hands. Palmer, the ER attending, stood frozen mid-step. Claire kept her hands on the patient, kept her voice steady. Right now, Sergeant, you're the one who needs saving, and I'm going to do that. But I need you to stay calm and let me work. Yes, ma'am. He smiled despite the pain. Always did follow your orders, Doc. She turned to the surgical team, pushed past the stares, the questions forming on everyone's faces. This patient has a grade 3 splenic laceration with active bleeding and a probable hemothorax. We need to move now. Someone page the OR and tell them we're coming up emergent. Her voice carried command, the kind that came from making calls when lives hung in the balance and hesitation meant death. People moved, following her orders without question this time, responding to something in her tone that transcended titles and hierarchy. Brennan stepped into her bay. Dr. Ashford, what exactly? Later, she said. Right now this man is bleeding to death. Are you going to help me save him or not? He looked at her, really looked at her, seeing someone completely different from the quiet second-year resident he'd dismissed. Let's move, he said. They rushed the patient toward the elevator, toward surgery, and Claire felt the weight of revelation pressing down on her shoulders, knew that everything was about to change, that the quiet anonymity she'd built was gone. But James Cordero was alive on her table, and that was all that mattered. The OR was prepared when they arrived, lights blazing white, instruments laid out in precise rows. Claire scrubbed fast, muscle memory taking over, the familiar ritual grounding her, even as questions burned in the air behind her. Menon scrubbed beside her, silent, his face unreadable behind his mask. Afghanistan, he said finally. You served in Afghanistan. Yes. How long? 2 tours. 4 years total. And you never mentioned this. It wasn't relevant. Wasn't relevant? His voice carried an edge. You have combat surgical experience, and you didn't think that was worth mentioning during your residency application. I mentioned it. It's in my file. No one ever asked about it. She pushed through the doors into the surgical bay, hands up, letting the nurse glove her. Cordero was already under, his chest and abdomen prepped, monitors showing vitals that were holding but fragile. BP 85/50, heart rate 140. He was compensating, but barely. We're racing his blood loss, Claire said. I need to get proximal control of the splenic artery before we lose him. She made the incision, midline laparotomy, the blade moving through tissue layers with practiced speed. Blood welled up immediately when she opened the peritoneum. Dark, venous blood mixed with brighter arterial bleeding. Suction. The field cleared for a second, then filled again. He's got a liver laceration too, she said, hands moving, packing the area with surgical gauze. And the spleen is grade 4, not 3, complete hilar disruption. Brennan was across from her now, assisting. His hands steady despite the questions Claire knew were building behind his eyes. "Can you save the spleen?" he asked. "No, it's shattered. Splenectomy is the only option." She worked fast, hands moving in patterns she'd performed in far worse conditions. Intense with generators failing. In the back of vehicles on roads that were more craters than pavement. In darkness lit only by headlamps, while mortars landed close enough to feel the percussion in her chest. This was clean by comparison. Bright lights, full instrument trays, anesthesia that wasn't just ketamine and prayer. Clamp, ligature, suction. The rhythm was almost meditative. Identify, isolate, control, repair. Each step building on the last, each decision made in fractions of seconds, hands moving faster than conscious thought. Brennan watched her work with an expression that had moved past skepticism into something else. Comprehension, maybe, or the beginning of it. "Your technique," he said. "It's not what we teach here. It's faster. It's aggressive. It's effective." She tied off the splenic artery, began mobilizing what remained of the spleen. In trauma, you don't have time for delicate. You need to stop the bleeding, stabilize the patient, and get them to a place where they can heal. Everything else is secondary. That's battlefield medicine. That's medicine that keeps people alive. She removed the spleen, placed it in the specimen basin, moved to the liver laceration. It was bleeding, but not catastrophically. She packed it, applied hemostatic agents, checked for bile leaks. "His pressure's coming up," the anesthesiologist said. 95/60. Heart rate dropping to 120. "He's stabilizing," Claire said. "Keep pushing fluids. We're not out yet." The doors opened behind them. Yuki's voice came through. "Dr. Brennan, 2 more critical patients just arrived from the collapse. Dr. Palmer needs surgical consults in the ER immediately." Brennan didn't move. "I'm in the middle of a case." He said, "It's urgent. Multiple casualties. More coming." Claire looked up from the surgical field, met Brennan's eyes across the table. "Go," she said. "I can finish here. You're a second year. I've done this surgery 43 times under worse conditions than you can imagine. Go help the other patients. I have this one." For a long moment, he didn't move. Then he stepped back from the table, stripped off his gloves. "Close perfectly," he said. "I always do." He left, and Claire was alone with the surgical team, with the patient who'd recognized her, with the truth that was spreading through the hospital like ripples in still water. She repaired the liver, checked every quadrant of the abdomen for missed injuries, irrigated thoroughly, prepared to close. "Dr. Ashford?" The scrub nurse, a woman in her 40s named Angela, spoke quietly. "Is it true? What that patient said? You were really in Afghanistan?" "Yes." "And you saved his unit?" "I did my job." "He called you a hero." Claire's hands paused, just for a second, over the closing sutures. "Heroes are people who have a choice. We were just trying to survive and bring everyone home. That's not heroism. That's desperation with a medical degree." She finished the closure, layer by layer, fascia and subcutaneous tissue and skin. Her interrupted suture pattern, the one Yuki had recognized. The one that came from operating in conditions where every stitch had to hold against infection and limited follow-up care. "Patient is stable," the anesthesiologist said. "Ready for recovery." "Good." Claire stepped back, let the nurses take over the final steps. "I want hourly vitals for the first 6 hours. Watch for signs of hemorrhage or infection. He's at high risk for post-splenectomy complications." She stripped off her gown and gloves, pushed through the doors into the scrub room. Her hands were steady as she washed, but she could feel the exhaustion building, the weight of exposure, the knowledge that her carefully maintained separation between past and present was dissolving. The ER was chaos when she got downstairs. 5 patients in various bays, all from the construction collapse. Nurses moving between them. Doctors calling orders. The controlled urgency of a mass casualty event in a facility that had the resources to handle it. Claire moved to the first open bay. A young man, maybe 25, conscious but in shock. Compound fracture of the femur, bone visible through torn tissue. She assessed quickly, ordered x-rays, started pain management protocols. Bay 3 had a woman with a head injury, pupils unequal, signs of increasing intracranial pressure. Claire called for a CT, started mannitol, elevated the head of the bed. Bay 5 was an older man, chest trauma, possibly flail chest. She ordered imaging, started oxygen, prepared for possible intubation. She moved between patients with efficiency born from experience, triaging not by who was loudest, but by who was dying fastest, by who had minutes versus who had hours. Brennan appeared beside her in Bay 5. How many can you handle? As many as keep coming. He looked at her, really looked at her, and she saw the recalculation happening behind his eyes, saw him reassessing every interaction they'd had, every dismissive comment, every assumption. The patient in Bay 7, he said. Multiple penetrating trauma to the abdomen. Palmer thinks it's surgical, but he's not sure. I need a second opinion. Show me. They moved together to Bay 7. The patient was a construction worker in his 30s, pale, diaphoretic. Multiple puncture wounds across his lower abdomen from rebar that had pierced through falling debris. Claire examined the wounds, felt the abdomen, watched the patient's face. He's got peritoneal signs, rigid abdomen, guarding. These penetrated the peritoneum. He needs exploratory surgery. You're certain? I've seen this injury pattern before. Different cause, same result. If we wait, he'll develop peritonitis and sepsis. He needs to go up now. Palmer was standing nearby, listening. With all due respect, Dr. Ashford, his vitals are stable. We could observe. His vitals are stable because he's compensating, but he's bleeding internally and his gut is perforated in multiple places. Observation means watching him die slowly instead of saving him now. That's quite an assumption. That's pattern recognition. Claire's voice was calm, but carried weight. I've treated penetrating abdominal trauma from shrapnel, from IED fragments, from gunshot wounds. The mechanism is different, but the physiology is the same. This patient needs surgery within the next hour or his survival rate drops by half. Brennan was watching her, his earlier skepticism completely gone. How many trauma cases have you treated? Hundreds. I stopped counting after the first tour. Make sure you subscribe to Emergency Hero Stories, because what happens next will change everything at St. Catherine's Hospital. Drop a comment and let us know what you think Dr. Ashford should do. The overhead speakers crackled. Trauma alert, GSW to the chest, ETA 3 minutes, patient unresponsive, CPR in progress. Everyone froze. Gunshot wound. And CPR in progress. The words that meant someone was probably already gone, that everything they were about to do was a desperate attempt to pull someone back from the edge of death. Claire felt something shift inside her, felt the old reflexes engaging, the combat surgeon rising to the surface. I'll take it, she said. Brennan stared at her. Claire, I'll take it. Get the other patients to surgery. I'll handle the GSW. He's been down for 15 minutes, according to ENS. He's not dead until I say he's dead. Get me a trauma bay and a thoracotomy kit. Now. The ambulance came in screaming, lights flashing red and blue through the ER bay doors. 2 paramedics doing compressions on the gurney, pumping hard, faces set with the grim determination of people who knew they were probably working on a corpse, but wouldn't stop until someone told them to. Marcus Chen, 19 years old, the lead paramedic shouted as they rushed past. Single GSW to the left chest, found unresponsive at a convenience store shooting. Down at least 15 minutes before we arrived. We've been doing CPR for 12 minutes. No pulse, no respirations. Pupils fixed and dilated. They transferred him to the trauma bay. Claire was already there, gloved, gowned, the thoracotomy kit open on the tray beside her. The same name as the first-year resident, she noted distantly. Different person, 19 years old, barely older than some of the soldiers she'd treated. She looked at the patient, pale, lips blue. No chest rise despite the bag valve mask the paramedic was pumping. Blood soaked through his shirt, dark and spreading. Stop compressions, she said. The paramedic stalked. Everyone looked at her. Claire placed her stethoscope on his chest. No heart sounds, no breath sounds on the left side. She felt for a pulse at his carotid. Nothing. He's been down too long. Palmer said from behind her. Claire, there's nothing. There's always something. She picked up the scalpel. Until there isn't. Resume compressions. The paramedic started again, hard and fast, the patient's chest compressing with each thrust. Claire made the incision. Left lateral thoracotomy, 5th intercostal space, the blade cutting through skin and muscle in one smooth motion. She'd done this before, in a tent, outside Kandahar, with a 22-year-old Marine who'd taken shrapnel to the chest and stopped breathing. He'd lived. She opened the chest with rid spreaders. The mechanical click, loud in the suddenly quiet bay. Everyone was watching now, residents and nurses and techs, all of them seeing something they'd probably never seen before, something that belonged in war zones and last-ditch efforts. The heart was visible, not beating, just sitting still in the chest cavity, a dark muscle that should have been moving but wasn't. "Stop compressions," Claire said. She placed her hand on the heart, felt its temperature, its texture. Still worn, still viable, maybe. The bullet wound was visible in the left ventricle, small entry hole, edges ragged. Bleeding had stopped because there was no pressure, no circulation, nothing moving. "Suture," she said. 4-O-proline. "And I need him on bypass and we have it available." "We don't have bypass in the ER," Palmer said. "Claire, this is." "Then I work without it." She threaded the needle, placed her first suture directly into the heart muscle, closing the hole in the ventricle wall. "Everyone else, clear the bay except essential personnel. If you're not actively helping, get out." People moved. Some left. Some stayed, rooted by the impossibility of what they were witnessing. Claire placed 3 more sutures, closing the wound in the heart. Then she began internal cardiac massage, her hand literally squeezing the heart, trying to restart the rhythm, trying to force blood through vessels that had been empty too long. "Squeeze, release, squeeze, release. Come on," she said quietly. "You're 19. You don't get to die at 19. Squeeze, release, squeeze, release." Brennan was beside her now, not speaking, just watching her hands work, watching her try to resurrect someone who by every measure should have been declared dead 10 minutes ago. "Claire," he said softly. His brain has been without oxygen for over 25 minutes. "I know. Even if you restart his heart. I know. Squeeze, release, squeeze, release." She felt something, a flutter, a single, weak contraction under her palm. "There," she breathed. "There. Come on, again." Another flutter, then another. The heart trying, muscle memory kicking in, electricity firing through tissue that wanted to live. "Get me epi," Claire said. 0.1 milligrams, direct cardiac injection. A nurse handed her the syringe. Claire injected it directly into the heart muscle, then resumed massage. Squeeze, release, squeeze, release. The heart contracted on its own. Once, twice, then settled into a weak, irregular rhythm. "I have a pulse," someone said, voice shocked. "Faint, but it's there." The monitor started beeping, slow, erratic, but present. 40 beats per minute, then 50, then 60. "Get him to the OR," Claire said. "Now, I need to close this chest wound properly and repair any other damage. Move." They rushed him out, the monitor beeping steadily now, the impossible save rolling down the hallway towards surgery. Claire stood in the empty trauma bay, blood on her gown, her gloves, her arms. The thoracotomy kit spread out like evidence of what she'd just done. Palmer was staring at her. "I've never." "He's not saved yet," Claire said. "He could still die on the table, or wake up with severe brain damage, or develop a dozen complications. But he has a chance now. He didn't before." "Where did you learn to do that?" "Afghanistan. We called it battlefield resurrection. When someone goes down and there's no time for proper protocol, no time for anything except getting your hands directly on the problem and fixing it. That's not standard civilian practice. Standard civilian practice would have called him dead at the scene." Brennan stepped forward, his face carrying an expression Claire couldn't quite read. Respect, maybe, or something more complicated. "My office," he said. "Now." Claire stripped off her gloves, her gown, washed her hands in the bay sink. The water ran pink, then clear. She dried off, followed Brennan through the ER, past the stares of residents and nurses, who just watched her do something that would be talked about for months. His office was small, neat, diplomas on the wall, a desk covered in organized stacks of papers. He closed the door behind them, gestured to a chair. Claire sat. Brennan remained standing, arms crossed, looking at her, like he was seeing her for the first time. "Tell me everything," he said. "Everything is a long story. We have time. The OR won't be ready for another 15 minutes, and you're not scrubbing in covered in that patient's blood. So talk." Claire leaned back, felt the exhaustion creeping in at the edges. "I joined the Army after medical school, did my residency through the military, deployed twice to Afghanistan, worked in forward surgical teams, combat support hospitals, and sometimes in the field when there was no other option." "How many combat surgeries?" "I stopped counting after 800. Could be over 1,000 by the time I left." Brennan's expression didn't change, but something in his eyes did. 1,000 trauma surgeries. And you came here as a second-year resident. The military doesn't have a civilian residency equivalency program that most hospitals recognize. I have the experience, but not the credentials, so I start over. Why not stay in the military? Claire looked at her hands. Clean now, but she could still feel the weight of that heart in her palm, the desperation of trying to squeeze life back into tissue that had given up. Because I was tired, she said quietly. Tired of making decisions based on who had the best chance of survival instead of who needed help most. Tired of operating in conditions where we didn't have enough of anything except casualties. Tired of watching command make choices that cost lives because of politics or optics or bureaucracy. So you left. So I left. And I came here to learn how to be a doctor when you have resources and time and the luxury of treating patients as individuals instead of statistics. Brennan sat down heavily in his chair. I owe you an apology. You didn't know. I didn't ask. I saw a second-year resident from a county hospital and made assumptions. I was wrong. You were doing your job. Residents need supervision. You don't need supervision. You need... He stopped, seemed to reconsider. What do you need, Claire? She thought about it. About what she'd wanted when she'd walked into St. Catherine's 6 weeks ago, with a carefully constructed civilian identity and a determination to leave her military past behind. I need to be allowed to do my job, she said, without being questioned at every turn, without having to prove myself with every patient. I need autonomy to make the calls I know are right, even when they contradict protocol. That's asking for a lot of trust. I've earned it. You just didn't know I had. He studied her face, the lines of exhaustion around her eyes, the quiet confidence that came from having done the impossible enough times that it became routine. The patient upstairs, he said. The GSW. What are his chances? 20% he makes it through surgery. 10% he wakes up neurologically intact. 5% he survives without major complications. She paused. But 5% is better than 0, and 0 was what he had 15 minutes ago. You knew those odds when you started. Yes, and you did it anyway. That's the job. Brennan stood, moved to his desk, pulled out a file. Claire's file. He opened it, flipped through pages, stopped at one near the back. It says here you received a commendation for surgical excellence under fire, he said. Multiple commendations, actually. And he stopped, reading something that made his face go still. Claire, is this accurate? She knew what he'd found. The citation she'd requested be kept out of her main credentials. The recognition she didn't want defining her. Depends what you're reading, she said. It says you received the Medal of Honor. Honor. The words hung in the air between them like something physical, something with weight and gravity. Yes, Claire said quietly. The Medal of Honor. The highest military decoration, and you never mentioned it. It's not relevant to civilian medicine. Not relevant? Clan, it's a piece of metal for doing my job under bad circumstances. That's all. It doesn't make me a better surgeon. It doesn't save more lives. It's just a reminder of a day when too many people died and I happened to keep some of them breathing. Brennan set down the file. You saved 23 people during a base attack, under active fire, for 19 hours straight. 23 people out of 46 casualties. I lost 23. The medal doesn't mention them. Claire, her pager went off. The OR. They were ready. She stood. I have a patient who needs surgery. Can we continue this conversation later? Brennan nodded slowly. Go, save him. We'll talk after. Claire left the office, walked toward the surgical floor, and felt the weight of exposure settling over her shoulders, like a familiar coat. The surgical bay was quiet when Claire entered, already scrubbed, gloved, the weight of what she was about to attempt settling into her bones like cold. Marcus Chen lay on the table, chest still open from her emergency thoracotomy. The sterile drapes arranged around the wound she'd made in the ER. His heart was beating now, weak but steady, the monitor showing a rhythm that shouldn't have been possible 20 minutes ago. Yuki was across the table, assisting. 2 other residents stood back, observing. The anesthesiologist, a woman named Dr. Reeves, monitored vitals with the intense focus of someone who knew they were managing a patient who existed in a space between alive and not. BP is 70/40, Reeves said. Heart rate 90. He's holding, but barely. Claire looked down at the open chest, at the heart she'd literally held in her hand and squeezed back to life. The bullet wound repair was holding, the sutures intact, but she needed to assess the full damage. Check for other injuries the initial trauma might have hidden. Retractor, she said. Yuki handed it to her. Claire expanded her view, looking at the left lung, the major vessels, the structures around the heart. The bullet had missed the aorta by millimeters, a few degrees different, and there would have been nothing she could have done. No amount of skill or desperation that could have saved him. Left lung has a through and through, she said. Upper lobe. I need to repair the entry and exit wounds, then check for air leaks. She worked methodically, each suture placed with precision, closing tissue that had been torn by a bullet that had probably been fired from less than 10 feet away. A robbery gone wrong. A 19-year-old in the wrong place at the wrong time. A life reduced to statistics and trauma codes. Except he was still alive. There's hemorrhaging near the pulmonary artery, Yuki said quietly, her voice steady despite what Claire knew she must be feeling, watching this impossible procedure unfold. I see it. Claire placed a vascular clamp, isolated the bleeder, sutured it closed. Suction. The field cleared. The bleeding stopped. They worked in silence for 20 minutes, repairing damage, checking and rechecking, making sure nothing was missed. Claire's hands moved with the automaticity of extreme experience, each motion flowing into the next, no hesitation, no doubt. This was what she was, not the quiet second-year resident who deflected questions and kept her head down. Not the woman trying to escape her past by burying it under civilian credentials. This was Dr. Claire Ashford, combat surgeon, the person who'd performed 11 surgeries in 19 hours while rockets landed close enough to shake the surgical tent. Who'd refused evacuation 3 times because there were still patients who needed her. His pressure's coming up, Reeves said. 80/50. Heart rate stabilizing at 85. Good. Claire checked the heart one more time, examined her repair work, confirmed the sutures were holding. He's not out of danger, but he's stable enough to close. She began the closure, layer by layer, repairing the thoracotomy she'd performed in the ER. Ribs approximated, muscle layers sutured, subcutaneous tissue closed. Finally, skin. The interrupted suture pattern, the one that marked her as different, as other. As someone who'd learned medicine in places where every technique had to account for limited follow-up and high infection risk. When she stepped back from the table, the monitor showed stable vitals. Heart rhythm regular. Blood pressure holding. Oxygen saturation climbing toward normal. He's going to ICU, Claire said. Neurological checks every hour. I want to know the moment he shows any sign of waking up or any sign of deterioration. Dr. Ashford, one of the observing residents, a young man whose name tag read Patterson, spoke hesitantly. I've never seen anything like that. Hopefully you never have to. What I did down in the ER, opening his chest without proper setup, direct cardiac massage, that's desperation medicine. Edison. It's what you do when every other option is gone and the only choice left is trying or watching someone die. But it worked. This time, I've done it 4 other times in my career. 3 of those patients died anyway. The odds are terrible. The complications are numerous. It's not something you do unless there's literally nothing else left. Yuki was watching her with an expression Claire couldn't quite read. Not awe exactly. Something more complicated. Understanding. Maybe. They transferred Marcus to ICU, monitors beeping their steady rhythm, a team of nurses surrounding the bed like guards, protecting something precious. Because that's what he was now. A miracle that needed defending. Claire stripped off her gown, her gloves, washed her hands in the scrub room. The water was hot. Almost too hot, but she didn't adjust it. Just let it run over her skin, washing away blood and betadine and the physical residue of the surgery. The door opened. Brennan entered, still in his surgical scrubs, looking like he'd just come from another case. He's stable, Claire said before he could ask. I heard. The ICU is calling it the resurrection surgery. You're going to be famous. I don't want to be famous. Too late. He moved to the sink beside her, started washing his own hands. The hospital administrator wants to meet with you. The chief of medicine wants a full report. And there are already 3 news outlets calling about the construction site casualties and the miracle save in the ER. Claire closed her eyes briefly. I just want to do my job. Your job just became a lot more complicated. Brennan dried his hands, turned to face her. Claire, you can't hide anymore. What you did today, what you've been doing since you got here, it's not something that stays quiet. People are going to ask questions. They're going to want answers. I know. So what do you want to tell them? She thought about it, about all the careful deflections she'd practiced, all the ways she'd learned to minimize her past, make it smaller, less significant, just another line on a resume that didn't need examination. But Sergeant Cordero had recognized her. The surgical team had seen her work. Brennan had read her file, had seen the citation she couldn't hide anymore. The truth, she said finally. I'm a trauma surgeon who served in Afghanistan. I have extensive combat surgery experience. I came here to transition to civilian medicine and learn how to practice in an environment with adequate resources. That's it. That's the whole story. That's not the whole story. The Medal of Honor is not relevant to my capabilities as a surgeon. It's recognition for one day, one event, one set of circumstances. It doesn't define me, and I don't want it to be the first thing people know about me. Brennan studied her face. You're asking people not to make a big deal about something that is, by definition, a very big deal. I'm asking to be judged by the work I do now, not the work I did then. Can I ask what happened, that day you received it? Claire was quiet for a long moment, staring at the water circling the drain. Remembering sounds and smells, and the weight of decisions made in fractions of seconds. Bodrum Airfield, she said quietly. August 2021, during the evacuation. Coordinated attack, rockets and ground assault. The surgical tent took a hit. Partial ceiling collapse. We had 46 casualties in the first hour, most of them critical. Command wanted to evacuate medical personnel, said the position was too dangerous to maintain. She caused, and memories sharp as scalpels. I refused, because those 46 people needed surgery immediately, or they'd die, and there was no way to evacuate them safely while they were unstable. So I stayed. Operated for 19 hours straight while the attack continued around us. 11 different surgeries. Lost power 3 times. Ran out of blood products twice. Had to improvise instruments when the supply line was cut. And you saved 23 people. Lost 23 others. The citation doesn't mention them. Doesn't mention the Marine who bled out while I was working on someone else. Or the Afghan interpreter who died because we couldn't get her evacuated in time. Or the soldier who survived surgery but died 3 days later from complications I couldn't prevent because we didn't have the right antibiotics. Her voice was flat, clinical, the way she'd learned to talk about trauma when emotion would break her. So yes, I received the Medal of Honor, and I appreciate the recognition. But every time I look at it, I see the faces of the people I couldn't save. That's why I don't display it. That's why I don't talk about it. Because it's not a symbol of success to me. It's a reminder of limitations and losses, and the fact that being good at your job sometimes still isn't good enough. Brennan was quiet for a long moment. When he spoke, his voice was gentler than she'd ever heard it. You know that's not your fault, right? The people you lost, you did everything humanly possible. Knowing it intellectually and feeling it emotionally are different things. Is that why you left the military? Part of it, I was also tired of making decisions based on resource scarcity instead of patient need. Tired of triage that prioritized mission readiness over human value. I wanted to practice medicine where I could treat every patient like they mattered equally, where I didn't have to choose who lived because we didn't have enough supplies for everyone. She dried her hands, turned to face him directly. I came here to be a better doctor, Dr. Brennan. Not a famous one, not a decorated one, just a better one. Someone who practices medicine the way it should be practiced, with time and resources and the luxury of giving every patient everything they need. That's all I want. Brennan nodded slowly. Then that's what we'll try to give you. But Claire, you need to understand something. What you are, the skills you have, the experience you bring, that's rare. Incredibly rare. This hospital would be foolish not to recognize that and use it to help more people. I'm not opposed to helping people. I just don't want to be defined solely by my military service. Fair enough. He headed toward the door, paused with his hand on it. For what it's worth, I'm sorry I dismissed you when you first arrived. I made assumptions based on superficial information. That was my failure. not yours. You weren't wrong to be cautious. Residents do need supervision and guidance. You're not a typical resident. No, but I'm trying to be. He smiled slightly. Stop trying. Be who you actually are. This hospital needs that person more than it needs another typical resident. He left, and Claire stood alone in the scrub room, feeling the weight of the day settling onto her shoulders, the exhaustion creeping in, the knowledge that everything had changed and there was no going back to quiet anonymity. Her pager went off. ICU. Marcus Chen was waking up. She ran. The ICU was dim, monitors glowing in the half-light. The steady beep of machines tracking lives that hung in careful balance. Marcus Chen was in the isolation room at the far end, surrounded by equipment, his chest rising and falling with mechanical assistance from the ventilator. But his eyes were open. Claire moved to his bedside, checked the monitors first. Heart rate 80, blood pressure stable, oxygen saturation 96%, all better than they had any right to be. Marcus, she said softly, can you hear me? His eyes tracked to her face, slow but deliberate. Conscious movement. Don't try to talk. You have a breathing tube. But if you can understand me, blink twice. He blinked. Once. Twice. Release flooded through her, sharp and unexpected. Neurologically intact, responsive, aware. The 5% chance had come through. You were shot, she said, keeping her voice calm, clinical. You've been in surgery. You're in the ICU now. You're going to be okay. But you need to stay calm and let the machines help you breathe. Blink twice if you understand. 2 blinks. Good. Your family has been contacted. They're on their way. Just rest now. She adjusted his IV, checked the ventilator settings, made notes in his chart. Behind her, she heard footsteps. Dr. Helen Voss, chief of medicine, entered the room with Brennan beside her. Dr. Voss was 58, gray hair cut short, eyes that had seen decades of medicine and missed nothing. She'd been Navy Medical Corps in the 90s, served on hospital ships, understood both the military and civilian worlds. Dr. Ashford, she said, a word please. Claire followed them to a small conference room off the ICU. Voss closed the door, gestured to a chair. Claire sat. Brennan stood near the window, arms crossed, expression unreadable. I've reviewed your file, Voss said without preamble. The complete file, including the sections you requested, remain confidential. Doctor, Brennan informed me of the situation, and I pulled your full military records. Claire waited, knowing what was coming. You're not a typical second-year resident, Voss continued. You're an experienced trauma surgeon with over 1,000 combat surgeries, multiple commendations, and a Medal of Honor for extraordinary heroism under fire. You have skills and experience that exceed most of our attending physicians. And yet you've been treated as a junior resident for 6 weeks. That was my choice, Claire said. I wanted to learn civilian protocols, adapt to a different practice environment. I didn't want my military background to overshadow that process. I understand that, and I respect your desire for a clean start. But what happened today changes things. You performed an emergency resuscitative thoracotomy in our ER and saved a patient who was clinically dead. You managed multiple trauma cases from a mass casualty event with the efficiency of a seasoned trauma surgeon. You can't put that genie back in the bottle. I'm aware. Voss leaned forward. St. Catherine's has been trying to establish a comprehensive trauma program for 3 years. We have the facilities, the equipment, the support staff. What we've lacked is leadership with the right experience to design and implement protocols that work in high-stress, resource-critical situations. Someone who understands both the theoretical and the practical aspects of trauma medicine at the highest level. Claire felt where this was going, felt the walls closing in on the quiet civilian life she'd been trying to build. I want you to lead that program, Voss said, not as a resident, as an attending trauma surgeon with full privileges and autonomy. We'll create a modified position that recognizes your military experience as equivalent to civilian fellowship training. You'll have complete authority over trauma protocols, training programs, and case management. Dr. Voss, before you object, let me finish. I know you came here to escape command structures and bureaucracy. This isn't that. You'll have autonomy to practice medicine the way you think it should be practiced. No one second-guessing your decisions. No one questioning your expertise. You report directly to me, and I don't interfere with medical judgment. I'd only care about results. Claire looked at Brennan. You're okay with this? Having a former second-year resident suddenly become an attending with authority over trauma protocols? I'm the one who suggested it, Brennan said. After watching you work today, after reading your file, after understanding what we've had walking our halls for 6 weeks without recognizing it. Yes, I'm more than okay with it. I think it's exactly what this hospital needs. Voss pulled out a document, slid it across the table. This is a formal offer. Full attending position, salary commensurate with experience, complete surgical privileges, authority to design and implement a trauma training program based on your combat medicine experience. And one more thing. She pulled out another document, an official request form. I want you to establish a training program specifically for military veterans transitioning to civilian medicine. You're not the only experienced military surgeon who gets buried in residency requirements, because the system doesn't know how to recognize combat medicine expertise. Help us fix that. Claire stared at the documents, at the offer that would change everything, that would drag her past into her present and make it impossible to separate the two. I left the military because I didn't want to be defined by it, she said quietly. This isn't about being defined by your military service, Voss said. It's about using the skills you gained there to save more lives here. You've already proven you can do both. Today you saved at least 4 people who wouldn't have survived without your intervention. How many more could you save if you had the authority and resources to implement your knowledge across an entire trauma program? Claire thought about David Morrison, the appendectomy that wasn't. The motorcycle accident victim with the hidden pneumothorax. Sergeant Cordero with his shattered spleen. Marcus Chen, 19 years old, who'd been dead until she refused to accept it. 4 people in 3 days. 4 lives that continued because she'd been there, had seen what others missed, had known what to do when protocol failed. What about the residents? She asked. The ones who've been working alongside me as a peer, how do they handle suddenly taking orders from someone who was their equal yesterday? They handle it by learning from one of the best trauma surgeons in the country, Brennan said. Claire, you're worried about hierarchy and perception, but those residents watched you save Marcus Chen today. They watched you manage a mass casualty event with precision that most attendings couldn't match. They're not going to resent your promotion. They're going to fight for the chance to learn from you. Voss tapped the documents. I need an answer by tomorrow morning, but I'm hoping you'll say yes, because what you did today, that's not something we can afford to waste on bureaucratic residency requirements. That's something we need to build on. Claire picked up the offer, read through it slowly. The salary was generous. The authority was real. The opportunity to create something new, to help other veterans navigate the transition she'd struggled with, that was meaningful. But it meant accepting that she couldn't separate her past from her present. Meant acknowledging that the combat surgeon and the civilian doctor were the same person. That the experiences that had shaped her in war zones would define her in hospitals too. Can I ask one thing? She said. Of course. I don't want the Medal of Honor to be part of how I'm introduced or promoted. I don't want it used in marketing or publicity. It's personal, and it's complicated, and I don't want it to become the headline that overshadows the actual work. Voss nodded. Agreed. Your military service will be acknowledged as relevant experience, but we won't sensationalize it. The focus will be on your surgical expertise and your ability to train others, not on decorations. Claire set down the document, looked at both of them. I need the night to think about it. Fair enough. Voss stood, extended her hand. Whatever you decide, Dr. Ashford, it's been an honor having you here, even if it took us too long to recognize what we had. They left, and Claire sat alone in the conference room. The offer in front of her, the weight of the decision pressing down like physical force. Her pager went off. Sergeant Cordero, awake and asking for her. She went to his room, found him sitting up slightly, color better, smile genuine despite the pain he must have been feeling. Doc, he said, they told me what you did. Taking out my spleen, fixing my liver. Said I would have died if you hadn't moved so fast. You're tough, Sergeant. You would have made it. Don't deflect, ma'am. I know what combat surgeons look like when they're being humble. You saved my life. Again. He paused. Why didn't you tell anyone here what you did over there? What you are? Because I wanted to be seen for what I can do now, not what I did then. Respectfully, ma'am, those are the same thing. You don't stop being a combat surgeon just because you're not in a war zone anymore. Those instincts, that training, that's who you are. Pretending otherwise doesn't make you a better civilian doctor. It just means people don't know how good you really are until it's almost too late. Claire smiled slightly. When did you get so wise, Sergeant? I learned from the best. He settled back against his pillows. Whatever you're deciding, Doc, decide based on where you can help the most people. That's what you always told us. Mission first, ego second. This place needs you, really needs you. Don't let pride or fear keep you from accepting that. She stayed with him a few more minutes, then made her rounds. All her patients were stable. All of them alive because she'd seen what others hadn't, acted when others hesitated, refused to give up when giving up would have been easier. At midnight, she went to Brennan's office. He was still there, reviewing cases, coffee cold on his desk. I accept, she said from the doorway. He looked up. The position? Yes, all of it. The attending role, the trauma program, the veteran transition training. I accept. What changed your mind? A sergeant who reminded me that hiding who you are doesn't make you better at your job. It just makes it harder for people to trust you with the work that matters most. Brennan smiled. When can you start? Tomorrow, but I have conditions. Name them. I want Yuki Tanaka as my primary resident. I want authority to pull in any other residents or attendings I need for cases. And I want regular case reviews where we examine failures as thoroughly as successes, because that's how people learn. Done. Anything else? Yes. I want that Medal of Honor citation removed from anywhere it's publicly visible in my file. It stays in my official record, but it doesn't get mentioned in introductions or press releases. Agreed. He stood, extended his hand. Welcome to the attending staff, Dr. Ashford. Try not to make the rest of us look too incompetent. She shook his hand, felt the weight of the decision settle into place, felt something that might have been relief, or might have been terror, or might have been both. 2 weeks later, the trauma program officially launched with Claire as director, 3 months after Claire Ashford became the director of St. Catherine's trauma program. The hospital's survival rates for critical trauma cases had improved by 23%. The training room on the 4th floor was full every Tuesday morning. Residents and attendings crowded around the simulation tables, where Claire demonstrated techniques most of them had only read about in journals. Damage control surgery, resuscitative endovascular balloon occlusion, emergency thoracotomy protocols. But more than the procedures, she taught them how to think under pressure, how to see patterns in chaos, how to trust their hands when the monitors screamed and everyone else froze. Yuki stood beside her now, assisting with a demonstration on a high-fidelity surgical mannequin, calling out vitals while Claire walked the group through decision trees for penetrating chest trauma. The key is recognizing when protocol fails you, Claire was saying, her hands moving through the simulated procedure. Textbooks tell you what should work in ideal conditions. Experience tells you what actually works when nothing is ideal. You need both, but when they conflict, trust the patient in front of you more than the algorithm in your head. A young resident in the back raised his hand. Dr. Ashford, how do you develop that kind of instinct? The ability to know when to follow protocol and when to break it. Repetition and consequences. You do enough cases, you start seeing patterns. You make enough mistakes, you learn what failure looks like before it happens. There's no shortcut. You have to put in the time and stay humble enough to learn from every case, especially the ones that go wrong. She finished the demonstration, answered questions for another 20 minutes, then dismissed the group. Yuki stayed behind, helping pack up the equipment. You're good at this, Yuki said. Teaching. You make complicated things feel manageable. That's because I learned most of these techniques when nothing was manageable. Compared to operating in a tent with mortars landing outside, a fully equipped OR with experienced staff is practically relaxing. Do you miss it? The military? Claire? Ree was quiet for a moment, considering the question honestly. I miss the clarity, the mission-focused simplicity of it. Everyone there because they chose to serve. Everyone working toward the same goal. But I don't miss the limitations, the resource scarcity, the triage decisions that valued strategic importance over human life. So no, I don't want to go back, but I'm grateful for what it taught me. Her pager went off. Trauma alert. Multiple vehicle collision on the interstate. 5 critical patients incoming. They moved together toward the ER, that familiar rush of adrenaline, sharpening Claire's focus to a fine point. 3 months in, and she still felt it, that edge of anticipation before chaos arrived. The ER was already transforming, bays prepped, teams assembling. Claire moved to the charge board, started assigning cases based on incoming reports, matching skills to injuries with the practiced efficiency of someone who'd managed mass casualty events in far worse conditions. The first ambulance arrived, then the second, then 3 more in quick succession. The organized environment shifted into controlled chaos, multiple cases running simultaneously, Claire moving between bays, supervising, guiding, intervening when needed. In Bay 3, a resident froze during a chest tube placement, hands shaking. Patient's oxygen saturation dropping. Claire stepped in smoothly. You've done this before. Block out everything except your hands and the anatomy. Feel for the intercostal space. There. Now advance the tube. Good, just like that. The tube went in, the patient's sats climbed. The resident exhaled shakily. Next time you won't need me, Claire said quietly. You just needed to trust yourself. Remember that feeling. That's competence under pressure. By the time the last patient was stabilized, 2 hours had passed. All 5 survived. All 5 would recover. The kind of success rate that would have been impossible before the program launched, before Claire brought combat medicine protocols to civilian trauma care. She was writing notes in the residence area when Brennan found her, holding a folder. The board meeting reviewed the quarterly reports, he said. The trauma program numbers are exceptional, survival rates up, complication rates down, average time to definitive care reduced by 18 minutes. They want to expand the program, bring in more staff, possibly establish St. Catharines as a regional trauma training center. Claire looked up from her notes. That would require significant infrastructure investment. They're willing to make it, because of what you've built here. What you've proven is possible. He set down the folder. There's something else. The Department of Defense is requesting permission to send military surgeons here for civilian trauma training. They want to adopt your transition protocols for active duty medical personnel preparing to return to civilian practice. How many surgeons? Initially 4 per quarter. Could expand if the program proves effective. Claire thought about the other surgeons like her who'd struggled with the transition, who had skills the civilian world desperately needed but couldn't properly credential, who'd felt lost between 2 worlds that spoke different languages, despite treating the same conditions. I'll need additional staff, at least 2 more attending trauma surgeons to help with supervision and training. And I want final say on which cases the military surgeons observe and participate in. Done. Dr. Voss already approved the hiring budget. Brennan sat down across from her. You know what this means, right? You're not going to be able to stay out of the spotlight anymore. Regional training center, military partnership, the survival rate improvements. It's all going to attract attention. Media attention. I know. And you're okay with that? I'm okay with saving more lives. If attention comes with it, I'll manage. She paused. As long as the focus stays on the work, not on me personally. The program matters. The techniques matter. The training matters. I'm just the person implementing them. You're the person who made them possible. I'm one person who made them possible. The residents who show up every Tuesday to learn, the attendings who adapted their practice, the nurses who embraced new protocols, they're all part of this. Leadership gets too much credit, and frontline workers get too little. I won't let that imbalance define this program. Brennan smiled. You know, when you first arrived, I thought you were going to be a problem. Turns out you were exactly what we needed. We just couldn't see it. You weren't wrong to be skeptical. I gave you no reason to think I was anything other than what my credentials showed. You gave me plenty of reasons. I just wasn't paying attention. He stood. Staff meeting Thursday to discuss the expansion plans. I'll need your input on equipment priorities and training schedules. I'll have something prepared. He left, and Claire returned to her notes, but her mind was already moving ahead, thinking about curriculum development, about how to structure military to civilian training, about which protocols needed adaptation and which could transfer directly. Her phone buzzed. A text from Sergeant Cordero, fully recovered now, back to work at the construction site. A photo of him with his crew, all of them wearing hard hats, all of them smiling. The message said, "Still here because of you, Doc. Don't ever forget that." She saved the photo, added it to a folder on her phone that held dozens of similar messages. David Morrison sent her updates every week, pictures of his kids. The motorcycle accident victim, fully healed, had completed a charity ride to raise money for trauma research. Marcus Chen, the gunshot victim, who'd been dead for 15 minutes, had started college, studying to become a paramedic. Lives that continued because she'd been there, because she'd seen what others missed, because she'd refused to give up when giving up would have been easier. A young woman appeared in the doorway, mid-20s. Nervous energy visible in the way she stood. "Dr. Ashford, I'm Sarah Reeves. I have an appointment." Claire checked her schedule, remembered. Sarah Reeves, former Army combat medic, starting the military to civilian transition program, the first of what would hopefully be many. "Come in, sit." Sarah sat, hands clasped tightly. "I'm not sure I belong here. I'm just a medic, not a doctor. And everyone here seems so confident, so competent. I feel like I'm going to mess up and prove that military medical training doesn't translate." Claire heard herself in those words, heard the self-doubt she'd carried when she first arrived, the fear of being exposed as inadequate despite years of experience. "You know what the difference is between military medicine and civilian medicine?" Claire asked. "Resources, time, equipment." Context. Military medicine teaches you to make perfect decisions with imperfect information under impossible conditions. Civilian medicine gives you better resources but often less urgency. Both are valid, both are necessary. What you learned as a combat medic, the triage instincts, the ability to work under pressure, the pattern recognition, those are skills most civilian medical professionals never develop. You're not behind, you're just different. And different is exactly what medicine needs. Sarah's shoulders relaxed slightly. "Dr. Brennan said you were Army, that you served in Afghanistan. 2 tours, forward surgical teams, and combat support hospitals. Did you ever feel like you didn't belong here, in a civilian hospital?" Claire thought about those first weeks, the dismissiveness from Brennan, the skepticism from other residents, the constant need to prove herself, while simultaneously trying to hide the very experience that made her competent. "Every single day," she said honestly, "until I realized that belonging isn't about matching what everyone else does. It's about contributing what only you can. You have skills this hospital needs, skills that will save lives. Don't minimize them because they came from a different context. Use them because people are depending on you too." Sarah nodded slowly, something shifting in her expression. "Thank you for saying that, for building this program, for making it possible for people like me to find a place here. You already have a place here. You just needed someone to tell you that." Claire stood. "Come on, I'll show you the training facility and introduce you to the team. We start rounds in 20 minutes, and you're going to shadow me for your first week. Hope you're ready to move fast. I was trained by the Army, ma'am." Fast is all I know. They walked together through the hospital, past the residence lounge, where Claire had once sat alone and uncertain, past the ER, where she'd performed an impossible save on a patient everyone said was dead, past the surgical wing, where she'd proven herself case by case until the weight of evidence became undeniable. The hospital had changed in 3 months. More efficient, more confident, better equipped to handle the impossible cases that arrived without warning and demanded everything from everyone. But Claire had changed too. She wasn't hiding anymore, wasn't pretending to be less than she was, wasn't minimizing her experience to make others comfortable. She was Dr. Claire Ashford, combat surgeon, trauma program director, teacher, and healer. All of it at once. No separation between who she'd been and who she was becoming. The overhead speakers crackled. Trauma alert. Pedestrian struck by vehicle. Critical injuries. ETA 4 minutes. Claire's pager went off. Sarah's went off a second later. "Welcome to St. Catherine's," Claire said, already moving toward the ER, that familiar focus settling over her like armor. "Let's go save a life." They ran together down the hallway, toward the chaos, toward the patient who needed them, toward the work that mattered more than titles or recognition or the careful construction of identity, toward the place where Claire had finally learned that sometimes the right thing to do is stop hiding who you are and start using every tool you have to help the people who need it most. The ambulance pulled up, sirens wailing. Claire was ready. She was always ready. and she wasn't hiding anymore.